Okay, now I'll pass it back to you. Good afternoon, everyone. Welcome to our webinar on the accountable health communities. I'm happy to introduce to you Jennifer Ferries, who works with MyHealth, and she's going to be telling us about a new tool for screening patients, and it's part of the accountable health communities of the Route 66 Consortium. Jennifer?
All right, thank you, Berta. I'm glad to be here today. I wanted to share with you a cooperative agreement that MyHealth is conducting with CMS and the Tulsa Health Department. I'm going to just jump right in and tell you a little bit first about MyHealth. MyHealth is a health information exchange. We are a nonprofit coalition linking providers through data. We already get a live feed from all of the Hillcrest and Utica Park clinics, so we're leveraging that technology to provide a mobile social needs screening. We're really excited about this opportunity and have piloted it already in a couple of Utica Park clinics out south, and we'll tell you a little bit more about that in just a little bit. So to start with, in 2016, CMS released an opportunity for this. It's like a grant. I call it a grant. It's not. It's a cooperative agreement, which is essentially a grant just with some different rules. MyHealth applied for that and put together a consortium to work with providers and community resource agencies in Tulsa and Oklahoma County. So in 2017, the spring of 2017, they received notice that they were awarded the grant for 5 years. We spent the first year kind of getting it up and running, building the program, testing it, and we actually went live in August of this year. I will tell you that MyHealth is just one of 32 organizations implementing this program around the country, which is kind of exciting. We've been able to work with other groups in Boston and Texas and Minnesota. So everyone's implementing the same screening tool in different ways. And I will tell you that our method is very different than what a lot of other organizations are doing because we have the ability to leverage technology to do the screening. So a little bit about the study itself. The study is funded by CMS, and what CMS is trying to do is they are trying to determine if identifying and addressing social needs will reduce healthcare cost and utilization. Frontline providers and those that work in clinics know that this impacts health behaviors and your overall health and well-being. And so we're excited that CMS has decided to study this. We think it's long since coming. What we hope or what we think will come out of this is some sort of model that CMS will put together where there'll be some reimbursement opportunities for doing these screenings for patients in clinics. We're excited to see what the results are. We have another 3.5 years on the study, so we still have lots of time to implement this and get some really good results. The study itself is screening for 5 major social needs. That includes housing insecurity and quality, food insecurity, transportation needs, utility needs, and safety and interpersonal violence. And I'll talk a little bit about those more specifically here in a little bit. So the way this works is MyHealth is the bridge organization. And essentially what we do is we connect clinical delivery sites like hospitals, clinics, behavioral health centers with community resources in their community. So in Tulsa, we've partnered with lots of great agencies like Catholic Charities and Iron Gate, the Food Pantry, DBIS. We've partnered with them to connect people with needs that are identified after being screened at their doctor's office with resources in their community. So what MyHealth's job is to actually provide the screening in a way that minimizes impact for clinics. I will tell you we piloted this. Dr. Kendrick is the CEO of MyHealth, and he is kind of who sought this grant and who led the charge. He piloted this study at the Bedlam Clinic here in Tulsa, which is a low-income, mostly no-insurance clinic. And he did it in the clinic. It took between 12 to 14 minutes to screen people using the CMS questions. And obviously no clinic wants to do that. It's way too much time for it to be done in a way that works in clinical settings. So he went back to the drawing board and kind of thought, how can we do this in a way that isn't demanding so much of clinics? And so he came up with this idea of texting the screening to patients. When he was doing the pilot in the Bedlam Clinic, he found that 100% of the patients that he saw in the clinic had cell phones, even though they were low income, no insurance, a lot of them. And so that kind of made him think, hey, what if we utilize this technology along with the feed we get from clinics connected to MyHealth to have patients take the screening on their own device? And we also felt like that maybe patients would be more comfortable asking or answering sensitive questions on their device versus having to do it in the clinic face-to-face with someone. So the way it works is we actually text a screening instrument to the patient. They take the survey. Then if they indicate that there is a need, we actually provide them a link back to their cell phone with an individualized list of resources. Those resources are all pulled by zip code, so they will match, for example, say they have a food need. We will provide them a food resource like Catholic Charities, one that we know is a really high quality, that has, we know what the requirements are, we know how often patients can go there. So we're going to provide one really high quality resource, but still in their zip code area. The second resource we'll provide is a statewide service. So for example, for food, we might provide information on how to apply for SNAP. Then the third resource will truly be the closest food resource to their home. We use data pulled from a database that we've created that matches the services with their home address. So it really is an individualized resource for each person that takes the screening. Then after they take the screening, if they identify as having a need and then they are identified as high risk, and the way CMS describes high risk or defines high risk for this study is patients who have been to the emergency room more than once in 12 months, so 2 times or more. So those patients will actually be referred then for navigation services, which we have partnered with Oklahoma City and Tulsa County Health Departments, and we have hired navigators who sit at those locations who will then reach out by phone to the patients who have identified as high need, high risk, and have a need. And they will reach out and help them get to resources. For example, help them make phone calls to the food pantry, help them get a ride to the food pantry. So that referral is really great. The only piece of that is that CMS is paying for the study, so the people that are qualified for navigation services are those from who have Medicaid or Medicare. One thing that MyHealth is doing for this study is we are actually offering to screen every patient that walks in a clinic door. So regardless of if they have insurance or not, if they have private insurance, or if they have Medicaid or Medicare, we are providing a screening to any patient that comes through, because we know needs don't exist just with Medicare and Medicaid patients. So everyone will receive a text with a screening, and then that information will then be returned in a report format to the health system, either to the clinic level or to the system level, that can then be divided out to the clinics. So that clinics and social workers can follow up on some of the most high-risk patients, even if they don't qualify for the Accountable Health Communities navigation services. So that's a little overview of how it works. I'm going to show you a little pathway here in a minute, and I'll talk a little bit more about the technology part. But the last thing that is our job is to build relationships with people in the community, agencies that are going to be providing these services. Myself and the navigators have all been out making connections so that we really have a good resource of referrals. So the way that this works is when the patient checks in, we actually get a live feed from your clinic that comes straight to MyHealth. So we know when someone checks in the office it's essentially real time, within a few minutes. At that point, it generates a message to us, and we use that message. We pull the mobile phone number out of that message. We then send a mobile phone number to our partners, Twilio. Twilio receives no PHI, no patient information. They just receive a batch of phone numbers from us. from that phone number, a text is sent out that says, please take the screening linked below. It's from your healthcare provider. They would really appreciate you taking it. It can link you to free or low-cost resources. It's a really short kind of intro. We've actually already kind of tweaked that a few times and may continue to do that to provide the most information to the patient with the least amount of wording. So they receive a link, and the link is here on this slide if you would like to go take it. This is a link to the demo. It shows exactly what the patient will see. It starts with, do you want to take the screen in English or Spanish? And then from there, it will provide all of the next information in the language of their choice. So it gives them a chance to view the privacy notice if they would like. Then it asks for qualifying questions from CMS, and those are basically just, who are you taking the survey for, yourself or someone else? How many times have you been to the emergency room? And do you live in the community? So another piece of the survey is that, or the screening from CMS, is that you have to be a community dweller. And what that means is that you live in the community. You don't live in a nursing home. You don't live in a prison. So they are looking at the social needs of community dwellers. Then you go through the social needs questions, which are on those 5 core areas, and finally it asks some demographic questions. The patients can actually skip any question in the screening they want. They don't have to answer it, and we actually collect the data as we're going through. So if someone only gets through the food and housing questions, but they indicated they had a need, we will collect that, and we can send them resources based on those questions answered. So again, like we talked about, those screening questions, or when the patient answers those screening questions, as soon as they close the survey, those answers and that survey does no longer live or exist on their phone. So they actually follow the link to a web page, they answer the questions there, and once they close it, no one can ever see those results again. We've tried to really be careful in thinking about this, especially with knowing people may be answering some information about domestic violence, but there is no way for anyone to see what they answered to any of the questions after they close the link. Then every few minutes, MyHealth goes and pulls the results back from the surveys that have taken, and we match those in our system with the demographic and patient information we receive from the clinic. And then we use that to match with that matched patient data, and the survey results is what is used to provide that information back to the clinic, as well as provide that information to the navigators. So at no point is a patient's PHI disclosed to anyone, just from the clinic into MyHealth system. So again, everyone receives a social needs resource summary, no matter their insurance, and then those with 2 or more ER visits are navigated. So this is kind of the way it works. Essentially, the patient checks in, which is the only thing you can see in the clinical delivery site line. That's the only thing we need the clinic to do. Then MyHealth sends a screening via text message to the patient. The patient receives this text, completes the screening. MyHealth processes the results, and if there's no health-related social need, that's the end. If there is a health-related social need, we send them out. We create a customized referral summary and send it via text to the patient, and they get the link to that. Again, with domestic violence, we've thought a lot about this, and so if someone indicates they have domestic violence issues, we're not going to just send them 3 domestic violence resources. We're going to also give them food and transportation and some other need resources, just basically so that if someone would happen to see that they don't see immediately that they disclosed domestic violence to someone. In addition, sort of like the screening, the link to the summary, the custom resource summary, does not live on the patient's phone. And so if the patient looks at it, they go to a web page to view it. They can save that somewhere else, in an email, somewhere more secure. But once they close out of the resource summary and delete that text, it does not live on the phone anymore. So we really tried to think about the clinical implications of people completing the screening and hoping that they will complete it in an anonymous way, but then for us to give them back data that is safe and reliable. So then if the patient, again, is Medicaid or Medicare, they get referred to the navigator. So as you can see, most of the burden of this processes on MyHealth. So the next thing is kind of what is the job of this facility, the healthcare facility, and what is the benefit to you? So really all we need you to do is be a MyHealth member, which Hillcrest and Utica Square is a MyHealth member. We get real live data feed from you. So the only thing we're asking clinics to do is update their contact information at check-in. And from my experience with the Utica Park clinics, that's already happening. It's just asking the patient if they have new phone number or insurance information. And then just to encourage the patient to complete the screening and that it is from you. So we'll talk in just a second about what we're asking the clinics to say. The benefit to you is that you get social needs screening for all your patients with no additional workload. Your patients get resources and navigation services if they qualify, and then we also get all that screening data back to the provider. I will say that the screening does take the place or meets the requirements for CPC Plus clinics, so I know that's a big draw for a lot of the CPC Plus clinics. So basically what we're doing, this is some information on how to touch the patient and how to encourage them to take the screening. Really all of this part for clinical staff and discharge staff is optional. Right now all we're asking you to do is to have the registration staff update their information, which I think is already happening, and then just to notify the patient that they will receive a text message, it is from us, and then to encourage them to participate. So the way we've been working it out in the South Creek Utica Park is the front desk staff, all they do is they say, hey, I want you to know that you're going to be getting a health needs screening. It's from us. We'd really like for you to take it. And that's it. That's all we're asking. So that's really the sort of the overview. A few things to know about the program is right now it is set up through CMS to be for Tulsa County and Oklahoma County. MyHealth is required to screen X number of Medicaid and Medicare patients a year, but that's really on us. We are planning to apply for an extension to expand the geographic boundaries of the study, but at this point it is for Tulsa and Oklahoma County, so we're starting with clinics in those geographic areas. And then if there are any questions, this is my information, how you can get questions to MyHealth, specifically around AHC. And then we have also started piloting this week in a few more Utica Park clinics and are really excited about that process and getting a few more clinics up and running. So that's all I have to share for today. Verda, did you have any other thoughts or questions I can answer?
No, I think, Jennifer, you've covered everything. Thank you so much for sharing some additional information for us and for the clinics that are listening. Jennifer and I will be contacting the office manager for the various clinics to review some of this information again and to set up a go-live date for your clinic during the month of October. Thank you, Jennifer.
Thank you.